This is actually a topic that I got interested in, well, 12 or 13 years ago. When I first came to Los Angeles, I was at Harbor UCLA, and I had an interest in head injury and done a lot of head injury research over the years at UCLA and at Harbor UCLA. And I started working with Ron Swerdloff and Christina Wang, who are the endocrinologists down at Harbor UCLA, and we started our pituitary clinic down there. And we also started this project on the idea of pituitary failure after TBI, which stands for Traumatic Brain Injury, basically head injury. And I got interested in it because I kept hearing from the endocrinologist all the symptoms associated with hormonal failure, particularly things like growth hormone deficiency and low testosterone. And a lot of those complaints sounded very similar to the head injury patients that we see. You know, people after a bad brain injury complain of fatigue, depression, anxiety, they don't sleep well. There's a lot of things that, you know, they may have seemingly recovered from their head injury, but they're never quite the same. And so the question arose, well, could some of those changes be related to untreated pituitary failure? Because the gland is hanging down off the brain, it's potentially vulnerable. And so we started looking at this, and it turns out, of course, there's nothing really new under the sun, that this has been looked at over the years, but it had never really been studied very carefully. There were literally hundreds of case reports in the literature, but there were really no studies looking at how often does it occur, why does it occur, and what do you do about it, and what's the impact of treatment. And so we started this study down there and expanded it to UCLA, and ultimately had an NIH-funded, National Institute of Health-funded grant to study this for 5 years. And so I'm going to talk about that from the standpoint of how this study went and what we discovered along the way. So there are lots of people involved in this study, a number of whom I mentioned, including Dr. Cohan. But Dr. Cohan, Swerdloff, and Wang were the ones that were most involved with this. And so our basic hypothesis that we were trying to prove or disprove was that many head injury patients or victims suffer from unrecognized pituitary failure that acutely and chronically compounds the initial brain injury and can potentially limit the recovery. And just to give you some facts about head injury, if you don't know, it's really sort of the silent epidemic. There's about 500,000 head injury admissions every year in this country, of people coming into the hospital because of a bad head injury. If you think about brain tumors, there's probably 20 or 30,000 people a year diagnosed with a primary brain tumor, okay, like a pituitary tumor or meningioma. So head injury dwarfs the number of patients with primary brain tumors. There's about 100,000 patients require a craniotomy to remove a blood clot from the brain or repair a skull fracture. And there's around 75 or 80,000 head injury-related deaths every year. And unfortunately, the majority of people are younger people. So it does tend to be a disease of the younger population, although there's a second spike in the elderly population as well. And the number of head injury survivors is enormous. You can see the number there, 2.5 to 6.5 million people out there who've had a head injury. And of course the cost for taking care of these patients is really quite astounding as well. So we were looking specifically at this issue of how does a brain injury like this is a patient, this is a CAT scan of a patient, all this white is blood over the surface of the brain. This is obviously the bone here, but this lighter white is blood. This is called a subdural hematoma. It's a pretty common type of brain injury that we see. And you can see the shift of the brain from the hematoma. And so the question is, how does such an injury like this affect the pituitary stalk and the pituitary gland itself? And ultimately, how does it affect pituitary function? And We were specifically interested in looking at all of the hormonal axes, the growth hormone axis, the gonadal axis, testosterone, estrogen, looking at the stress hormone, ACTH and cortisol, and thyroid function, as well as diabetes insipidus, which is the posterior pituitary gland. So we're interested in looking at all of that. And if you think about the way the gland and the pituitary stalk are arranged, it's a potentially very vulnerable area of the nervous system. You can have direct trauma to the stalk or the gland, and then you can have a variety of what we call vascular insults, things related to blood flow. So if we know that with a lot of head injuries there's swelling of the brain and raised intracranial pressure, that's what ICP is, and that could compromise the flow going down to the gland. You can get spasm of these blood vessels, and then you can also get low blood pressure or hypoxia, which is decreased oxygen. If someone's knocked unconscious and they're not breathing well, they can have a sort of a stroke to the pituitary gland. And so it was thought that some of these factors were likely involved. And like I said, nothing's really new. In medicine, it seems, we went back and we found this original article published in 1959, actually the year I was born, of a patient who sustained a fatal head injury, and this is the preserved anterior lobe, and this whole area here is an infarct or a stroke of the pituitary gland. So they lost this whole area of the anterior pituitary gland. And so this was something that was known back then, at least that occurred in fatal head injuries, and it wasn't quite clear whether this was occurring in human head injuries. But it wasn't too long till some additional individuals did some very good studies in the 60s, and these are from a couple studies where they looked at the pituitary glands, basically an autopsy. They looked at the pituitary glands of people who died of a fatal head injury. And what you can see is that only about a quarter of these fatalities had a normal appearing pituitary gland. So there was hemorrhage in various parts of the gland, and there was this necrosis of the anterior lobe in over 20%. Interestingly, the pituitary stalk did not get lacerated or did not die in very many patients. So it seemed like more often there were these issues of hemorrhage and infarction. And then they also looked at the hypothalamus, which is the area above the gland where the gland gets all its signals from. And there, in those fatal head injuries in this particular study, they saw over 40% of these fatalities had abnormalities, mostly hemorrhages and ischemic lesions, meaning little infarcts within the hypothalamus. So at least in fatal head injury, it seemed like this was very common, that the pituitary gland and its related structures would get damaged fairly often. So we set up this study to look at the effects both acutely and chronically, meaning 6 months to a year after what we call moderate and severe head injury. Those are pretty bad head injuries. Most of the patients are in coma, that is, they're not following commands. Most of them have a breathing tube in place. And this is just showing the various types of injuries we get. Blood clot over the surface of the brain. Here's one that's layered right on the brain here, and then bleeding into the brain, what we call a cerebral contusion or an intracerebral hematoma. So there's a whole variety of different types of injuries that people can sustain. And so we were looking at these factors as well. One of the first things we did was we looked at the effect of brain injury on the stress response and adrenal function. And we looked at these in patients when they're in the intensive care unit, they're intubated, meaning they have a breathing tube in place, and we looked at their cortisol levels and their ACTH levels to see what was the pituitary gland doing. And the bottom line is, in this study, we found that half the patients had low cortisol and ACTH. So they 50% met the criteria for adrenal insufficiency. And so based on that study, and what the consequences of adrenal insufficiency are, is that if you don't have enough stress hormone, your blood pressure goes down, and you require more things to keep your blood pressure up. And so we found in that study that half the patients had that, and they had lower blood pressure, and they required more vasopressor support. They required more medications to keep their blood pressure up. And so from this study, we made the following recommendations: that depending upon what the level is, either patients should be treated or they should be carefully monitored. And we ended up doing a randomized trial of hydrocortisone, which is an intravenous steroid that we give patients in the ICU. And that study is completed, but I still don't know the results because we're still analyzing the data. We've just starting to unblind the data. And basically what we did in this trial was we took about 60 patients. Half of them got hydrocortisone for 4 days, half of them got placebo for 4 days, and we looked at what their blood pressure was over that time, and we looked at how much medication support they required. And I don't know what the results are yet. So maybe in one of our next meetings I'll tell you what the results are, but we're anxious to see what the results of that are. But nonetheless, this does happen quite often and probably needs to be carefully monitored acutely. So let's move on to the chronic phase. So what's important to understand about patients with head injury, if you have a moderate or severe head injury, most people don't fully recover for 6 months to a year. After about a year, you tend to plateau. So those patients are going to be about as good as they're going to get in terms of their neurological functioning, their psychological functioning, etc. And we published this original study back in 2000 with just 22 patients. And subsequently, there have been a whole bunch of publications looking in a prospective fashion, looking at how often does pituitary failure occur in this period where patients essentially have recovered from their brain injury. And presumably the brain is about as good as it's going to get. So these patients were all at least 6 months out from their injury. And what you see, and this is now in over 600 patients, and there's studies in Europe, studies in the U.S., studies from all over the world now looking at this, and everyone is finding approximately the same thing. But if you look at the numbers overall, about 40% of head injury patients are going to have some sort of pituitary injury after their head injury. And by far the two most common are the growth hormone axis and the gonadal axis. And it seems that these two axes are the most vulnerable. And this has been shown not only in head injury, but in other things such as surgery and the impact of radiation on the pituitary gland.
Kelly, have you ever seen in a head injury patient where actually the growth hormone went up? Like
Well, acutely it goes up in a lot of patients. The levels go up, sort of for whatever reason, we're not sure why that is, but the levels actually go up. But the somatotrophs, the cells that make growth hormone in the pituitary gland, are in an area where the gland seems to have its most tenuous blood supply, and as well as the gonadotrophs, the cells that make LH and FSH, which either stimulate the production of testosterone or estrogen. So the rates of new failure for these two are significantly higher than for thyroid or adrenal, which tend to be more resilient. And diabetes insipidus, permanent diabetes insipidus, is even more rare, only occurring in about 1 to 2% of these head injuries. But so you still have got a lot of patients who are developing some sort of deficiency. And the important thing is that until these studies were being done, there was not a lot of attention paid to this. This was not something that neurologists or rehabilitation doctors or neurosurgeons were really paying much attention to. That, part of the reason this person may not be functioning well is not just because he got his head whacked, it's because his pituitary gland got whacked as well, and the gland is not functioning normally. And so it's important because these deficiencies, which very much impact your quality of life and your day-to-day functioning, if you replace them, the patients will, in almost all instances, will do better. So it's a very treatable part of the brain injury if it's diagnosed. And the problem is that over many years that these things haven't been thought of. So from our study, we had 70 patients who we had long-term follow-up, and we found major deficiencies in 21% and minor deficiencies in 29%. And again, if you combine the major and minor, it's a little over 40%, so it's pretty common. These major deficiencies are things we would say that it would be standard to replace. That is, an endocrinologist would want to treat that. And so the other deficiencies were not that common. Diabetes insipidus, as I said. One of the things we're not really sure what to make of these minor deficiencies. We really don't know, are these significant? Because we did a fairly sophisticated testing of the gland. The patients get what's called stimulation testing of the gland. So there's some things that are not necessarily treatable, but they're abnormal. And whether or not that relates to how they're functioning, we're not sure. In terms of what's predictive of losing function, well, the findings on the CAT scan seem to be the most predictive, and the worse the injury on CT scan, the more predictive, more likely we're to lose function. That's not too surprising. As I mentioned, a lot of the complaints that people have after head injury are related to these neurobehavioral problems like memory, concentration, depression, fatigue. And these, in some ways, are very similar to growth hormone deficiency. Some of the complaints that people get with growth hormone deficiency, as well as low testosterone and even low estrogen in women. So, again, we wondered were these findings that we're seeing in these head injury patients related to untreated hormonal treatments. And so we looked at this specifically in a group of patients who were growth hormone deficient after their head injury. And I won't go into all these numbers here, but suffice to say we had 8 patients out of 44, 18%, who were growth hormone deficient. And when we looked at how they were doing at 6 to 9 months after injury, they were all depressed versus 47% of those who didn't have growth hormone deficiency being depressed. And they had more neurobehavioral deficits, not quite statistically significant. And they had poor quality of life based on some standard surveys that are done: physical and general health, energy and fatigue, emotional well-being, and pain. And so it does seem that these problems are related to how the individual is doing. And again, it's very treatable with growth hormone therapy. So from our study and many other studies that have been similar to ours, it seems like these hormonal deficiencies occur in probably around a third of these patients. The growth hormone and the gonadal axis are the most vulnerable, and it seems to be most often in these patients with more severe brain injuries. And so it should be really standard of care that these patients have hormonal testing beginning no later than 6 months after their injury. And replacement is probably the way to go, obviously. And certainly growth hormone may be helpful for some of these problems. And there are some trials going on. We had a trial going, but essentially we ran out of money and we ran out of funding and we had to stop the trial, so it will not be completed. Just the last point I want to bring up is the idea of, well, we know that moderate and severe head injury can cause pituitary failure. Well, what about recurrent concussion? For instance, in boxing, football, and hockey. And actually someone has looked at this, and not too surprisingly, in a group of boxers, growth hormone deficiency was seen in almost half of them, 5 out of the 11. And the more fights they had and the longer they were in the business, the more likely they were to have growth hormone deficiency. And this is an important concept, and it potentially relates to professional football. This is a study done by a group at University of North Carolina, and they looked at over 2,500 retired NFL football players. And you've heard a lot about the NFL players, retired NFL players, about how they're not doing well in the retirement years, many of them. There have been some suicides, there's a lot of depression, there's a lot of problems with their quality of life. And so in this study, you can see that they looked at a number of people. Their average age was around 50. They'd played an average of 7 years. 11% had reported clinical depression. But what they found, the strongest correlation between recurrent, in fact, there was a strong correlation between recurrent head injuries and a lifetime risk of depression. So the more head injuries they had, the more likely they were to have depression. And so we actually now have a study with this same group looking at pituitary function in the retired NFL players. And we haven't started it, we're just about to get underway with it. But we're going to be looking to see if their depression, their anxiety, these sorts of things, fatigue, relate to the number of concussions, and does the number of concussions relate to their pituitary function. So this is a study that we'll be doing over the next 3 years or so. And that's it.